must remain conscious of the realities within our healthcare systems. Access to highly specialized surgical services remains unequal, and we must continue across our continent. This requires collaboration. No single surgeon, institution, or country can address these challenges alone. We need stronger plastic and reconstructive surgery, not only in Kenya, but in the entire continent of Africa. Na tukiwaona hao, tunaona kwa to provide them with opportunities for mentorship, research, skills development, and meaningful professional development. This conference therefore provides, can translate into better outcomes for our patients. Over the next 3 days, I encourage all of us to engage fully with the program, ask questions, share your experience. As KSPRAS celebrates its 20th annual conference, let us take pride in the journey that has brought us here, while remaining ambitious about the journey ahead. Let us strengthen collaboration so that the future of microsurgery in Africa is not only technologically advanced, but also accessible, sustainable, and responsive to the needs of our patients. I would like to sincerely welcome to KSPRAS 2026. Thank you very much, ladies and gentlemen, for turning out to be here. Also, just take time to go out, relax, and enjoy yourself. Upigie mwili pole. Life is not just about surgery or Nairobi. Nairobi wakora ni wengi. Kini Mombasa, people are more gently. So just take time, go around, enjoy yourself. For the visitors who came here earlier, some have already. So thank you very much, ladies and gentlemen. This. So thank you.
I would like to say something about our chief guest. Unfortunately, our publisher decided to copy my CV and pick reconstructive and aesthetic surgeon, famously known as KSPRAS, which is actually turning 80 years this year. He's a fellow of the Royal College of Edinburgh, 2 surgical fellowships in hand surgery, and has visited multiple units in the US before starting as a consultant plastic surgeon. He is currently a consultant plastic and hand surgeon with the NHS renown, and has extensive experience in congenital hand surgery, upper limb reconstruction, adult and pediatric spasticity surgery, peripheral nerve assessor for the FRCS PLAST exam, and an external assessor of the British Society for Surgery of the Hand Diploma and MSc. He's also It's a great honor to have our chief guest for this conference, Professor Paul MacArthur.
Thank you. Waiting for the slides to come up. I first came to Kenya in 2019, and that was part of a charitable organization in the UK. Dr. Allura, as I know him now, previously Ken, as a 4th year medical student. Yeah, so you'll see some pictures later, and I've got other evidence, so if he tells you any dodgy stories, I'll, so first of all, I'd like to say thank you to Professor Nangolo for inviting me to speak and to be part of the associations and societies developing, and each year I attend, more and more is happening in Kenya, which is testament to the work, not just of the current teams, but the team set out. And certainly back in 2019, Professor Kayanga was instrumental in part of that organization. Thank you to the organizing committee for to date. The entertainment was spectacular. But I must say to Olive, is she there? There we are, for making all the arrangements for me. And there are some old faces that have a bit less hair, and that's me in the middle with the blue tie. So one of the things that I've been asked, plastic surgery began in the UK, many of you might know, in 1946 when Harold Gillies and McIndoe got together to decide that there is a specialty, KSPRAS as it was called then. The specialty arose really out of necessity, and that was for reconstruction of the world conflict, in fact. And what we learned at that time was that there was a need to work out how you could help people. And they devised a number of procedures. Harold Gillies became the first president, and the association set out at the beginning with one or two aims in mind. That was to uphold standards, advance education, and guide the specialty through the next phase. Now, Professor Nangole touched on all those things, and those key points in the outset of our association are heard across a number of other countries that I've visited. So the history and the milestones are here, as you see. In 1948, the British Journal of Plastic Surgery was launched. It's now become the Journal of Plastic and Reconstructive Surgery. And I'm pleased to see that you have your own journal now because, first and foremost, it promotes education, it promotes the spreading of the word, interaction amongst interested and scientists of similar fields. But from an association point of view, if you are able to work with your publisher, it's actually a very good income stream for your development into other. In 1999, the Healing Foundation, which is a charity set up in conjunction with BAPS at the time, British Association of Plastic Surgeons, donated £500,000 to that charity. For the trainees amongst you all, PLASTER is the Trainee Association of Plastic Surgeons. So trainees in plastic surgery have their own association in the UK. They have around, I think at the last count, 3,000 members, of which half are international members. It's free to join. There's lots of educational resources that you can access through that. Give it some thought and consideration. As I say, it's free to join, but it connects trainees around the world. It's with fellowship organizations as much as anything else. It was the same as BAPS, but we decided to include the reconstructive and aesthetic elements into our title. Important keystone, really, was workforce planning. Now, what that means is every year from 2010 onwards, so for the last 16 years, we send out a questionnaire to all the plastic surgery units in the UK. The information we receive is how many plastic surgeons do you have, how many are trainees, how many are going to retire soon, how many opportunities do you have for employment. And that allows us to predict what will happen, how many trainees we need to train, how many doctors we need to provide. There were various other keystones. The latest one is 2025 with the emergence of the virtual museum. KSPRAS has a vast collection of historic artifacts from surgeons of the past, from the units of the past, and we just simply don't have the physical space to have a physical museum. So my colleague, Mr. Martin Cody, has developed a virtual museum, and again, for interest, that might be something you want to look at. And again, as I was going to call him Ken again, Dr. Allura, to give him his formal title, mentioned 80 years for KSPRAS this year, and we will be celebrating. So what's the modern role of KSPRAS? Well, we have several, but the primary aim is to promote innovation, research, and education. So that is ethical education of not just doctors, nursing staff, and medical students. It's educating the public in what's available from plastic surgery, what to avoid the minefield of aesthetic and cosmetic field exit exams. And we have a royal patronage. And this is myself and Dr. Agarwala, who's our royal was. If patients want advice, they can come to us directly. We influence training so that all plastic surgery members of KSPRAS are fully certified in reconstructive and aesthetic surgery. And the responsibility for KSPRAS really is not just our current patients, but the patients of the future who may require and need reconstructive surgery, but also may be considering aesthetic procedure. So we do this through websites, which at my age is how I used to interact with people. Nowadays, websites, I'm told, are as old-fashioned as books. And so we have a media, online, social media forms. You'll also note a very old-fashioned word, it's print. We actually go out to the newspapers and the magazines and provide information and articles for the older population. So how do we keep patients safe, and who do we need to keep them safe from? Well, there's an emerging field of practitioners, and I've put that loosely because wherever I go in the world, and on this trip I've been in Sri Lanka, I've been in Singapore, and I've come here today, there is this increasing group of people who consider themselves practitioners who are offering medical level treatments with qualification. And we need to protect our patients from this. We also need to protect them from themselves, because very often many of the patients who come to you from an aesthetic point of view are seeing themselves very differently to how other people see them. And I always tell my trainees, and I always tell people who will ask me, what is the difference between an aesthetic procedure and a reconstructive procedure? And the answer is the reconstructive procedure is to restore the normal anatomy with an aesthetic eye, so you're returning unusual pathology anatomy to more normal. Whereas with the aesthetic patient, you have a normal patient in front of you. Anatomically, physiologically, they are normal. They just want to be a different normal. And that can be quite challenging. And of course, we have to consider, unfortunately, some of our surgical colleagues are more business orientated than they are necessarily clinically orientated. So we have a rapid evolution of aesthetic medicine and surgery, that should say. We've seen a 12% annual growth in the past 5 years. This is global, which when you compound that up is a 76% increase in aesthetic procedures around the world. And that equates to somewhere between 110, 130 billion US dollars. It's an enormous market. So you can imagine that people who are looking to, in the business world, develop new techniques are looking to introduce those techniques and machines and treatment options to doctors, to practitioners, so that they are used, and therefore that goes on to the patients. But patients' expectations are rising. Media coverage, we saw a huge increase post-COVID, because we were all sitting around in our houses communicating through Zoom or Teams or on our phones, and we saw ourselves differently. We were always looking down. When I see people taking selfies or having a photograph taken of themselves, the phone is up here. And it's up here for a reason, because you can't see the effect of gravity as much as if you're looking down. And you all know that. It's not a plastic surgery thing, it's just a fact. So the other point about patient expectations is more and more, depending where you are in the world, plastic surgery or aesthetic surgery can be seen as a normal day-to-day, everyday access point for the general population. If you take South America, for example, it's considered entirely normal. If you come to Northern Europe, however, it's largely there, but most people will see it as a luxury, if you like. So people coming expecting the best outcomes for the lowest price point. They want the best service, but they want a low price point. And as a consequence of that, they are prepared to travel. Innovations and so on we've talked about, I'm not on that again. The challenges to the patient in a changing landscape is basically, who do they trust? Who do they go to? They need a reliable source of information from trained plastic surgeons, such as you guys in Kenya through the KSPRAS Society. But if you look, going back to medical tourism, why do people travel? And it's very simple, it's in red. The main reason for medical tourism is a cost saving. Depending where you are, and if you travel, you can reduce your cost as a patient from up to 30 to 80%. And often are packaged, packaged with a week's stay in a nice hotel. When we look at the medical tourism market, again, it's a huge annual turnover of estimates of over $100 billion. That's a huge market that everybody wants a piece of. So how can we help? Well, again, it comes back to what we said before. We need to be fully trained. We need to get the messages out. We need to protect patients. Again, KSPRAS does it through, I think I'm going the wrong way here. No, there we are. Sorry, I've lost my screen. So, plastikos, the Greek word that plastic comes from. And it wasn't designed for plastic surgeons. You know, it was designed, or the first use of the word or anglicization of it was in the determination and naming of the material plastic. And what does plastikos mean? Again, most of you know this because it's usually the first 3 pages of any plastic surgery textbook. It means capable of being shaped, molded, or formed. Now, what we need to do as plastic surgeons, we can provide those skills to patients. That's our training. How we deliver that and how we tie into the new modern world. There's a lot of worry and concern about artificial intelligence. There's a lot of worry that artificial intelligence will take. Most of us are using a degree of artificial intelligence in our work week, whether that's managing our patient flow, managing our finances, managing our domestic lives. What they've done is they've integrated artificial intelligence to read the scanners to guide the surgeon through the tumor resection to reduce the impact on the normal brain. So it's there, part and parcel of the evolution of what we do. So I took a walk on the artificial intelligence high street, which is what our patients are doing. And I said, make me look 10 years younger. So there we are, 10 years younger, okay? That's fine. So I pushed it a little bit further and I said, look, make me look 20 years younger. And that's what it came up with. So this is a bit of fun. But actually what will happen, because they don't like that picture, they'll come with something that you can't deliver because it's impossible. Well, maybe the hair transplant perhaps, but that's about it. Services. From the past, we go back as far as Sushruta, from many, many years ago, the Indian Rhinoplasty meeting in November in Varanasi, which is on the river Ganges. And it's a very holy place for people of India. The people will go there and their bodies would be pushed into the river. And Sushruta set up his hospital, or his research in inverted commas, and the Italian Tagliacozzi in determining the variation of the tube pedicle flap, which was taken from the inner upper arm. This was then this print that it actually held back plastic surgery a little, but that's for people to debate. The biggest change in plastic surgery and reconstructive surgery was the invention of, they're not robots in the true sense, they are another instrument to allow us to work more safely. But then of course coming along the sidelines is artificial intelligence, and actual robots that can performs a microanastomosis in a. So these things are coming. And as the Chinese robot recently beat Usain Bolt's world record for the 100 weeks in Singapore, and this is the robot that was working in the hotel to check people in and check people out. There was also robot cleaners as well. So we are seeing the emergence of robotics, but we're a little far away from Arnie Schwarzenegger and the future. Plastic surgeons and as associations and societies of plastic surgery around the world are the custodians of best practice in plastic surgery. We have to remember that, we have to own it, and yet we have to KSPRAS Congress in Liverpool, the beginning of December. It's to celebrate our 80th year. We have many of the past presidents coming, and in Mombasa, and by the way I'm not, but if I was to set up a clinic there, what would the advert look like? And this is what it came up with.
Yeah, thank you. I'd like to invite Professor Nangole, Dr. Wabwire, Dr. Mkami, and yeah, thank you for
Kenya is known for lions. So we've got a lion carving that we really want to give you. And we'll give this opportunity to the first. We are really, really very grateful for finding time to be with us. We've really enjoyed your presentation. And equally, I remember when you visited. Unfortunately, most people here are either Man U or Arsenal.
So thanks a lot for that good presentation. And you can see the strategies you have in Britain, and we are preparing ourselves. We've got many practice. Thank you for what you've done, and to also show you that the lion in Kenya, not in Kenya, in Africa, I don't know. This statue of a lion, and we also hope that you pass through one of our game parks and see one live lion.
Lovely.
So this for you.
Thank you so much.
everyone.
Thank you. I am disappointed there aren't any Liverpool supporters in the audience, but the other, I have a glass rhino, a zebra, but the thing that takes pride of place in our and so on, because one of the things I find is that it's very easy for a Western surgeon to go to another country and demonstrate an amazing, fantastic technique, bringing their own
The Kenya Society of Plastic and Reconstructive. When we came to office, one of the things that we thought we should, our innovations, and also an opportunity to share our findings with the rest of the world. Now it's exactly 2 years since this was done. So I'll basically go through this just to share with you what have we achieved. Plastic and reconstructive surgery. I'm the editor-in-chief. We have the senior editors, which include Professor Hainga. And then we have, and our own Dr. Wanjeri from the University of Nairobi. And then we also have other members of the editorial. And then we also have Professor Dwar from Egerton University, who is here with us. And then we've got very young and very enterprising He's an editor with the East African Medical Journal for more than 15 years. And therefore, he's really helped us to establish this journal. And then, of course, we are the Society of Plastic and Reconstructive Society. And as you can see, when Professor Magatha was presenting, you realize that just 2 years after they formed the British direction. So it's sponsored by the Kenya Society of Plastic Reconstructive. It is a peer review journal. And all manuscripts are submitted to the journal. Our first scrutinized assessors will review it, and then finally, if it's accepted, then it will be published. Of course, the details for submission, like any journal, they're there. You'll be able, if you Google on the Pan-African journal, very important. In fact, there is a saying that if you want to hide something from an African, put it in a book. And actually, Professor Thumbaya will tell you that Africa, we contribute to less than 5%. Is it 1%? Of research, local journal that can encourage publications from Africa. Of course, share our knowledge and experience with the rest of the world. And one of the reasons why some journals will ask you to pay publication fee of as much as $1,000. Now, if your salary is less than $1,000, how are you going to pay $1,000 for publication? It is not possible. And then, of course, encourage publications from young healthcare workers and a timely and friendly review process. Now, it may look an understatement, but for those of you who've published, I'm sure you've heard those comments or communications from, I think I'll have to use the other one. So for those of you who've published, sometimes you can get comments from the reviewers which can be very discouraging, especially publish, because your article is not of interest to our readers. So I ask myself, but why did they spend all this time? And it's taken about a year, and eventually we are told. So it becomes very unfriendly. Duration from presentation to publication has been about 6 weeks or 2 months in general. And this I really want to thank the reviewers, because they've been very timely. And these journals have got very good information. Most of this work of these original articles has actually been contributions from the MEd research dissertations that have been published. And then we've got review articles which have contributed to about 2%, and then scientific communications, about 7% of the patient who was HIV positive. Now this was done by, the main author of this paper was actually one of our residents, and you can see that you find that the failure rate, at least in our hands, seems to be higher than in the general population. But in this case, we were able to get very good results, and the patient was able to heal and go home. Then, and in this case again, medial plunder flap was raised, which you couldn't raise anything from the foot. Now this child could not play. The paper that was published by Odor and Mugo. This was a microbiology of diabetic foot infections. Esura, I don't know whether he's around, but he looked at the likelihood of buttock lift. Majority of the patients who go for gluteal enhancement in Kenya are likely to recommend us and scientific comments. So we looked at what does AI talk about KSPRAS. Professor Magatha said that he also looked at AI to find but realities, wound management, and reconstructive challenges in East Africa and the wider continent. So we're like, oh yeah, this is great. At least this is what AIs that have been there for some time. For example, we know that KSPRAS have been there for a long time. Just look at how do they behave? What does the outside world look at? And therefore, 6. And then we looked at another one that was published in June 2026, 6 months different, reconstruction of complex axillary defect with free tissue transfer, what was captured in the article that was published in KSPRAS. Then we looked at another article that was published in the Archives of Plastic Surgery. Now, Archive of Plastic Surgery, that was published the importance of partnership with developing countries, how to establish a microsurgery course in Kenya. And again, we find that, and they muscle after extracompartmental excision of posterior thigh high-grade sarcoma. So we find that the readership for the one in was 40. The one that we had published in Pan-African Journal was 80. And we also found that even the research interest score was 1.5, and the other one was 2 points. Published in PMC Plastic Surgery, Lower Extremity, Free Flap Reconstruction in a Tertiary Trauma Center within a resource-limited health system. Again, this was published in January 2026. Superior medial pedicle need of nipple graft in the management of gigantomastia, again in March 2026. And still we found that the readership was 23 for the one published in PMC in January, and this other one was 76, which was marked difference between those two. And then we had another one that was published in PRS Global, the use of body Q to assess factors impacting satisfaction and quality of life post-abdominoplasty in Kenya, and reduction mammoplasty in the treatment of neck pain and shoulder pain. That, again, this was a paper that Chinondira was the main author. And again, we realized that the readership in the one of Pan-African Journal was quite good at 113. Even the one of PRS Global was equally good at 72. But the PRS Global had more citation of 3, but this other one was less, and the research interest Global was 4, while this other paper was still 0.5. And then another one, functional outcome of pediatric hand implantation with parent-assisted physio during COVID-19 pandemic, which was a case report, again published in April 2024, a year down the line. And the other one was, does excision weight correlate with narrative blood? And again, find that the readership was equally good with the research interest score that was literally matching. Society. The international reputation has increased a lot with increased numbers of readers with manuscript from other parts of the world. For the first 2 or 3, we be able to be put. And I'm very sure that if we're able to reach there, then actually our research index and impact factor to have their presentations being captured and published in this journal, we'll be more than happy to have them. This opportunity, first to appreciate the authors. The authors have really done us proud. And as I've already said, most of them are very young authors, which we really encourage to continue. And then of course the editorial board, as I had already shared. And then finally the readers, because you can publish some of the work that I published 5-10 years down ago. You look at it and you're like, nobody has ever looked at this work, and I spent so much time. Why is it not of interest? But as you can see with what I've already shown, that most of the work being read, and it has contributed in a big way in the scientific world as far as plastic, aesthetic, and reconstructive.
So if we have any questions to the presentations, we can ask now. You have 1 minute to put up your hand.
Excellent job. I think we should give the presenter a clap. It's a lot of work. Manuscripts, all the MEd thesis into manuscripts, as long as we plan ahead and in good time. But it needs to be a reasonable, affordable, but reasonable space, not...
Thank you, Professor Thumba. Professor Thumba, we need you in this journal as well. I know you're in many, many other journals, so I'm sure after this we'll be.
Thank you very much. That was part of the opening ceremony. Now you know we have a journal that you need to publish in, and it is read more than the PRS, the KSPRAS. I'm sorry, Prof. Anyway, because it was supposed to be now. Thank you. We'll go for the next session. I'll welcome Dr. Mukami and Dr. Ruben to take over. Have a good conference.
Session before lunch, guys get a bit jittery, but I think we'll do it a bit fast. We've just had tea, so we're giving you time to digest the tea. Germany rooted in a family heritage dating back to the 1970s. It's an internationally recognized luxury, beauty, and longevity brand founded on the belief that your body is your only 7 minutes. Sorry to put you on the spot. Karibu.
Asante sana. Good afternoon. Yeah, just, be patient a little bit for that, like details about it. You can ask me about it later. So if you can put up my slides, that would be great. Thank you. So my topic is the prevalence and morphology of cheek. So this was basically a study that I did within this country. So as you know, it's such a tiny feature in the face, but as surgeons, every decision that we make is, some people have it split. So when they smile, as it splits, the cheek goes in, which is kind of cool. So around 1960 to replicate that surgically for individuals who might want to have cheek dimples. So this point from Kubuchai's research in 1962 says that you draw a vertical line from the lateral canthus of the eye going directly down, and then you draw a horizontal line from the corner of the mouth, the oral commissure. So where these two lines intersect, that is where he says a dimple should be. So that's what we will now refer to as the KBC point. Stay with me. One question that I want you to keep in mind, I had like a number of objectives for the study, but one question that I'd like you to keep in mind is, do these dimples really all lie in the KBC point? So my study objectives were, number one, I was to determine the prevalence of naturally occurring cheek dimples among the Kenyan population. Number two was to describe their morphology, so their shape, their size, their depth. And then I was also supposed to assess if they lie in the KBC point. It was a descriptive and analytic cross-sectional study. My study population, my sample size was 200. I decided to do this among the students at the University of Nairobi, so I got 200 of them. And then the age was from 18 to 35. You can ask me why later. And then also, I had multiple ethnic groups. As you know, Kenya has so many ethnic groups. But we decided to go with the major ones, which is the Bantus, the Nilotes, and the Kushites. So what did we find? We ended up studying quite a lot of Bantus, because Nairobi is highly populated with the Bantus, and then we also had a number of Nilotes and then also Kushites, which made the number of 200. So one of my first findings was dimples are actually pretty common in Kenya, because this was a random, random sampling, and I found out that about 35.5% of people from this study population have dimples. That's kind of like 1 in 3. And then by prevalence, like I said, because we have so many Bantus, I feel like this was like one of my limitations or confounding factors, because I ended up having more people from the Bantu tribe who have dimples. But I also did find that the Nilotes have quite a number of dimples. And then the last group was the Cushitic group. And then most dimples were bilateral, but then not by much. There was like 56% of bilateral dimples compared to 43% of unilateral dimples. So if you look at this picture here, so where are the natural dimples? If you look at this picture, I tried to use pictures that look a bit different from each other, you can see just by looking at the picture that these dimples, yes, they're on the cheek, but are they all in the same spot? Do they all look the same? Are they circular? Are they linear? Are they curvy? So all of these things were things we were looking at. So what did they look like? We found that about 45% have circular dimples, and then for the depth, we had a mean depth of 8.4, so we used that as our moderate depth, and then anything higher or lower was like a deviation. And then we found that most dimples are in the middle of the cheek, they're of moderate depth, and most of them are circular. So shape also kind of influenced the size. We noticed that a more linear dimple has like a deeper depth, and then an irregular dimple has like a shallower depth. So back to the KBC point. So how often did my dimples, or my people that I studied, have dimples that coincided with the KBC point? 21.1%. So it looks as if 1 in 5 individuals have dimples that coincide with the KBC point according to this particular study. However, the difference was not so much. We found that the deviation was quite small. It was either, you can tell that some of them are smack in the middle, like the first guy in the picture, top left for you. And then if you look at the guy just below, what we noticed as is, so if the dimples are bilateral, 17.5% will coincide with KBC. There's like a symmetrical displacement for both bilateral and unilateral. However, the point may have been wrong, but not that much, like quite a very small difference for someone to say, oh no, KBC was wrong. So I'd say like they were remarkably symmetrical. However, my question still stands, like if you want to create a dimple for someone who comes and says, hey, daktari, nataka dimples, are you going to go back to what KBC said, or are you going to plan for the face in front of you? So take-home message, in conclusion for my study, cheek dimples were common in about 35.5% of patients, and then the natural morphology was mostly middle cheek, circular, moderate, and about 21% stands should we base it on KBC when we want to create cheek dimples for our patients. I don't know how much time I have. Oh, okay. I'm really sorry. I wanted to add something, but I think because without time, I'm going to stop.
Of a dimple, how will you explain that? I take this opportunity to welcome our next presenter, Dr. Keith Robertson. So Dr. Keith Robertson comes to us from Miami, Florida.
I've got 2 talks. One is on brachioplasty and the other is on biopolymers. Which one? Brief why the post-bariatric arm is different from the obese person, selecting the type of operation, and I'm looking at a few big studies just to see what scar is the best. I'll show you my technique that I do, and I do many of them. I do a very large amount of this procedure. So skin laxity without elastic recoil. So these people have lost a huge amount of weight, sometimes 50 kilograms. And we're seeing this more and more with, Mounjaro, Ozempic, and these medicines that are available, and people get them without prescription. So they may take them themselves. And it does seem to work. Short term is probably not the healthiest way to lose weight, but people come in with an excess of skin. Sometimes this skin is in the upper arm. It's usually in the midpoint of the upper arm. I examine the people in this position. And liposuction is fine for people that are heavy and that want their upper arm circumference to look like the circumference of the forearm, which would be the aesthetic goal. But with these people, we probably can't get there. so I usually do it with another part. The people that have massive weight loss, I usually wait for maybe a year or two after they've had their weight loss when they're stable, and I can combine the arm with another procedure. And this is especially, it can be quicker, you know, if you have an assistant can close one arm when you're doing the contralateral breast. So I use a pinch along the whole arm, and this is a technique that I use for the inner thigh, for the abdomen, for back lifts, and I'll show you that in a moment. So, and the abdomen. You can see that the forearm and the lower leg the skin will retract well after even after mass. So the most common adverse effect, this is, and this is not from my own work, but my own work has similar results to this. Medial placement or posterior medial placement, and I vary that according to the patient, according to the mobility of the skin and the excess of skin. These are just 3 areas to bear in mind with patients that can be problematic, or you think they may be a little litigious, or perhaps you want to do it in everybody, is to tell them that you will have numbness in your arm. And in some cases I have drawn on the forearm here a patch that may be numb afterwards, take a photograph of it and get them to sign it. So, as I said, I mark them standing. I usually support the arm. Very fit, and they cannot keep their arm like this for 5 minutes while you mark it. So in some cases I will have the patient put their hand on my shoulder like this, and on the patient on the left, where I've marked 49, the 49 refers to the mark to the right of the 49, and that is the maximum circumference, and that is the area that I want to remove. That refers to the line to the left of that, and then I have marked that I will remove about 30 centimeters of tissue here. It could be 11 on the other side, it could be, and the shape 40.5 and 13. This is more or less constant, and then the lower one varies. So I have to extend that line to the elbow, and sometimes a little bit advance up, or sometimes when I have raised up the flap, I advance it towards the corner, because if there's a dog ear, I want the dog ear to be in the driver. And both men and women, I see a huge percentage of drivers, of bus drivers, truck drivers. I guess it must be while you're sitting driving, you can eat, and they're quite different in shape. And you can see there's a little bit more excess skin on the patient's right side. Also, then on the sides, I have him with his arms over time. I do not do that in a massive weight loss patient. So I start the incision, and then using towel clips, I advance the dissected, and I don't often use a drain, perhaps in about 20% of the cases. So you can see the position of his arm. He had a lot of excess skin in the chest area, so I've recruited that skin back here this way. So I'm pulling it like this, and then pulling this back here, and then the measurement before, so that if the nurse, when she's prepping, if she scrubs everything off, I can remark it. And you can see the shape is quite different, and the groove between his biceps and deltoid, which okay, the photos are not the same, but you can see the festoons of skin on his arm and the breast tissue. So this was, you can see the tightness of the skin, and if you look very carefully at the top, you don't see this in all patients, so that banding actually existed before. It's important to point that out to them, point out to them also where the scar will be, because this is, you can see on the lower left photograph that there is a discrepancy between the size of the forearm and the upper arm, and this is due to a, so we have to use an ACE wrap, and the ACE wrap, invariably the patient moves it, and they usually move it up to the mid upper arm, and they trap and then they flex, and this gets worse. So this is for me the most common area of seroma occurrence. And I do see a lot of edema. Ideally, when we put on the ACE wrap, usually, like if you're doing a hand case, just start on the thumb and wrap the hand unequal, and you will have some areas of numbness. So takeaways, I mark. So I work in Miami, and I have a very large practice with these buttock biopolymers. I'm going to write a much more detailed paper on this in the future. Is quite similar to mine. In Miami, the prime language is Spanish, and I speak Spanish, and most of my patients are Spanish speaking. Americans are black, and I would say maybe in my patients 25%. So most are gluteal, most are women, and most do not have a clue what's injected. There is a correlation and just a brief story. Some of you have visited me in Dubai, and in Dubai there's a huge amount of this also. Coffee jar, and gave it to me. So this is what I was supposed to inject into patients, and I said, okay, no thank you, I won't do it. Behind me there came a doctor from another country, and she said, I'll take it, and I'll take everything you have, mixed with silicones and with oils. And for those of you practicing in Nairobi, this has already started here, and you have a bit of a lag phase. You're going to see the problems developing in a few years. The name biopolymer sounds cool, it sounds safe, and it's a simple, painless outpatient injection. Sometimes that I find here is industrial grade silicone. In the United States there's a big chain called Home Depot, and it sells silicone, as you can buy a big tube. It's like a big so people come to me, and some of them will say, I just want this removed because I heard it's that have had it done a few years ago. Some of them have really severe pain, and some it's unrelenting, they cannot sit down. With this group of patients, there's a huge cyclone flat. There is some dynamic going on with a lot of these patients and other family members, and it's not as straightforward as you might think. First of all, like a human, it smells. It is the most bizarre burning plastic type of smell. And during the operation, we have dense smoke. We have to use a smoke evacuation. This is a ruptured breast implant. So sometimes you have a combination of breast implants, other implants, oils and gels. You're popping bubble wrap. The interesting pattern of migration is that it tends to migrate to the sacrum, so they may present with pain in the sacrum. And I think this can be due to the pressure of sitting. It migrates up to the sacrum, and sometimes it migrates around to the transverse chain of lymph nodes. I have seen them go into the masses this big intravaginally, and I have also seen, which is strange, that it goes down to the lymph nodes around the knee. And I have not seen it migrate to the upper limb. Do not remove this with liposuction. These are my most problem patients, the one that a doctor said, yeah, I'll remove it with liposuction. So you put in a wetting solution which raises the interstitial pressure. You're going to drive these particles to other parts of the body. And those people, they tend to have, if you want to call it metastasis, they have spread of this to distant locations. So in the United States, it's very easy to get an MRI, so nearly all of my patients have an MRI. Intraoperative ultrasound, I don't use it that often, so you can see in the on the top to the left. This is the most classic finding in a Cuban person, and these are small balls of silicone contracted, if you see that MRI on the left, on the bottom left, so this one usually a hip dip, so that a lot of men have, but it's above the greater trochanter. And then on the lower right, you can see this stranding pattern. If it is all in the very deep layer, just over the muscle, then I would consider a fasciocutaneous. The incision, the approaches that I use, you can see this woman, she's bottom heavy, I mean the bottom of her bottom, and she doesn't have much superior. So if it is stuck to the skin, I will go right over that area, make the incision, and remove the bulk of it. And it's very clear, you tell them you will not remove all of this. You will remove one incision that I use is the curved incision above the buttocks. I've marked these lines are my guidelines, and they're every 5 centimeters. So I'm going to advance that up. In the upper pole, it helps a little in the lower pole. But unless the quality of the skin is excellent, you won't get a lower pole lift. Sometimes I use a hidden 6 centimeter paramedian incision, which would be in this lady just where the buttock cleft is. You would not see it with her standing, but when she lies down and the buttocks fall apart, you will see it. This is for someone that's concerned with more with the scar than with removing biopolymer. Now, on the left side, this photograph is one of the superior butterfly shape incision. It's above the gluteus, and I've made a deep tunnel there, fasciocutaneous dissection over the muscle, and removed some. I will then advance that up, and on the right side you can see what I sometimes do is I exaggerate the extent of that line. I make it more curved, because when you advance the buttock flap up, it's going to flatten that line. And what I want is I want to have a line which defines the buttock itself, which doesn't cross an aesthetic line. And so in some cases here I will remove that. Other cases I will remove the dermis and keep a dermal pedicle to give bulk to the upper pole. So you can see on the left here, you can see, look at the change in her skin. Now, she does have tattoos, but you can see the color change, that it can be purple with zero capillary refill, and you need to treat this as like a diabetic foot. This is a very compromised vascularity here. It won't do that. So you can see I have done this in the mid-buttock area, and I have advanced that up. You can see on the not connecting with the rectum and the colon, and she saw a colorectal surgeon before. It was close, but it wasn't connecting. So I'm advancing it medially and superiorly, and you can see while the shape is much better, there's a mismatch in color. So I've moved the ischiorectal fossa up. You can see a little at the superior aspect of the incision on our right, and that resolved with oral antibiotics. But if you combine, and her thighs look much more in proportion as well. This one on the left is where the biopolymers get some type of seroma. On the right, I've shown this. So in my opinion, it would look better with an exaggerated curve to make it more curved. And this is it combined with a body lift. So I did a tummy tuck, and then I have so complications, and these wound dehiscence, and I've told the patients before that this it has finally closed up to something on the right, and the right is closed. So tell them you cannot remove it all.
Thank you very much, Dr. Keith Robertson. And you're very right to say that this is indeed coming to Africa. I've had a couple of patients ask for the biopolymers. Very adamant they want the biopolymers, but we'll always discourage them. Yeah.
And, also, like I think I told a lot of you, but I'll be in Nairobi all next week if you have any.
Integra is a company that has really supported this society for many years. And they happen to have a booth outside. They have very interesting products, one of them being the Derma pen that you can look at. So Dr. Manal, welcome.
Good afternoon, everyone. I was told I only have 7 minutes to present, so I'll try and minimize the slides as well. So my name is Dr. Manal Bajaber. I'm currently doing M.Med Dermatology, the final year in JKUAT University. Can you all hear me? Okay. Is regenerative facial rejuvenation in Africa. Some disclosures, it's okay. So regenerative aesthetics, a different goal, loss and laxity. It's more about corrective and often very temporary. So I used to do a lot of fillers before, toxins and surface resurfacing lasers. The results, it's more about restorative treatment rather than just treatments that you have to keep on doing every 3 to 6 months, okay? So let's look at the clinical problem in Africa, isolation. So in deeply pigmented skin, the visible signature of aging differs from that of light-colored skin, which is mostly published in aesthetic literature. Precedes deep static wrinkling, lower tolerance for visible incisions, prolonged downtime in many treatments, like for example CO2 laser. Dark skin takes more time to heal compared to lighter skin. And also tissue. So combination protocols now pair a regenerative graft, for example the NanoFat, with an energy-based contouring step known as the lunchtime lift. Okay. Anatomic basis for facial aging, it's many changes that happen, and we have to treat it as a holistic approach. Changes. For example, bone resorption. A lot of women go through bone resorption. Not a lot, all women go through bone resorption faster than men. So perimenopausal women, I usually. Then there's muscular changes as well. We see muscle atrophy, which I usually combine a little bit of botulinum toxin as well, just as a holistic approach when it comes to aging well. The skin quality, because I think that's about 70% of what we do in terms of lifting. If the skin looks good, the lifting will look good as well. You can't just lift a patient's face and her skin quality or his skin quality. Cellular matrix, which reduce the skin's tensile strength and elasticity. So during the aging process, the proliferative and metabolic activity of fibroblasts decreases, and their functions are impaired, leading to preventing collagen degradation. And the number one thing to prevent collagen degradation is the use of sunscreen. Other things to stimulate collagen are lasers, which now is what I'll be talking about today, the lipolase laser lift laser, which is more of a laser that you put inside the skin. Then fractional laser is a type of laser that comes on top of your skin, on the skin. hyaluronic acid injections, polynucleotides, biorevitalization injection like mesotherapy, PRP, radiofrequency, glycolic acid use, and other AHAs, ascorbic acid, that's vitamin C, topical tretinoin, microneedling, and more. Microneedling actually stimulates collagen for about 1 to 2 years. Okay. So for lipolase laser lift, this is what I love to do now. I introduced it last year to the clinic, and I think it works really, really well for African skin because of the Fitzpatrick skin type 4 to 6 that we're dealing with in Kenya. Before, I used to do a lot of fractional laser, but fractional laser, the downtime is African skin, and stimulating collagen, you have to tell a patient to stay indoors for 7 to 14 days because of the sun, no sun exposure, so risk of post-inflammatory hyperpigmentation is less. But now with the lipolase laser lift, you'll see the results. It's amazing. Downtime is literally maybe a day or 2, and that's it. Okay, so how does a lipolase laser lift work? The technology, remember, is more about stimulation of collagen. So it's a diode laser operating at a wavelength of 1,470 nanometers. It's delivered through a fine during the laser with your foot switch. Okay, so you control it. And it's done under local anesthesia. We use the tumescent fluid. I make it very cold, and then very painful. So this works better for me now. So when I'm explaining to a patient why are we doing the lipolase laser lift, I tell them that it stimulates body's own collagen production, firming the skin. Okay. Someone else is controlling it, just a minute. So this is done around the periorbital region. Sorry. Oh, let me just go. Okay, then marking the treatment area, it's very easy. Usually you just mark the treatment area with a sterile marker, and then you draw the area that you want, the paths that you're going to take, about every 10, which usually reduce direct interaction with epidermal melanin compared with surface applied lasers, what I used to use before for darker skin types. Okay, so for after a year saying that, oh, the volume is not the way it used to be, I need more fillers, and more fillers. So it becomes very addictive, and it's very expensive as well. So now I recommend fat grafting, which is done, of course, it does cause some nodules. So you have to be very careful in which type of fat you're injecting where. So the macro fat mostly in deep structural volume. Then what do I use? In terms of dermatology, what do we use for? We do not perform liposuction. So I use the water jet assisted liposuction, which is liposuction done under local anesthesia. And okay, fluid delivered under gentle pressure through a thin cannula, which detaches the adipose tissue from its surrounding directly without depending on cell swelling or a mandatory weight. You're doing the botulinum toxin for axillary hyperhidrosis, but now they pay $200,000 for for the axillary hyperhidrosis using the water jet water assisted because of the rich stem cells that it has. And then I also make a nanofat cream for the patients to go home with, which combines metham to enhance the skin quality and just make it better. Yes, so remember in terms of keloid risk and just to minimize trauma, because you can add macrofat around the nasolabial areas and the marionette lines and the jawline as well. And this is a follow-up interval of after 3 weeks. And I also perform the laser lift for her. And the results are without the macrofat injections. So this is only by laser, and this is 3 months after. Remember, it gets better with time. Okay. So complications, of course, the normal complications that someone can get is...
It's okay. Thank you, Daktari, for your presentation. It was quite informative. Thank you. Next, sorry for keeping you waiting. I know lunch is waiting for us at Stanford University. And the section chief of plastic surgery at the Palo Alto VA Medical Center. She did her medical school. She trained at Yale University, University of Michigan, and
nerve compression. These are some of the people who've collaborated with this. This is new data. No one else has seen it. You guys are the first. Okay, so thank you for inviting me. All right, so the perineal nerve on the bone, it can become compressed and pinched, but we never think about it. So why should you think about it? And it's four things, and I'm going to go through. So Number one, people who were in the hospital who they thought might have a high risk, and about 30% of them had signs of perineal neuropathy. They looked at all comers coming into clinic, and 3% had perineal neuropathy. Terrible, and you're going to go see the doctor. What people don't realize is that they are thinking that they're clumsy because their toe keeps catching when they're walking down on every little ring. In the hospital who they found had a high risk, had this on there, had a 4.7 times more likely that they had a fall, an actual fall the last year. For the ones who were the 3%, a carpal tunnel. It's about the most fun surgery you can do. Local, MAC, really easy, and it is effective. All right, so I really got into this. All right, so then I wanted to do a study. Like, nobody can find these patients. Patients aren't complaining, and so my hypothesis was, well, maybe patients with carpal tunnel syndrome, maybe they would be to see if people with carpal tunnel syndrome might fall more often than other folks. And this was our thing. We had 63 patients that we looked at. There we go. Lots of good data. And we had 1.5 million people with carpal tunnel. And so what we found was that did a Kaplan-Meier, which is that little graph there. You can see that the people with carpal tunnel were more likely to fall and fall earlier at a younger age. Okay, study number 2. So if carpal tunnel, find it, we had 181 participants, and 34% of them had had a fall in the year before, which is way higher than average. And when we look, important predictor in our carpal tunnel patients who had falls. So lessons learned and next steps, these patients with carpal tunnel have high rates of falls. Physical exam for a good tool so that people who aren't plastic surgeons or aren't hand surgeons could maybe make this diagnosis to send them to us. Now there are a bunch of other slides. We're not going to go through them. Thank you.
Thank you so much. You can hear me. Thank you so much, Professor, for your presentation. I'll request all the presenters to come forward. Dr. Manal, raise up your hands if you have any question for our presenters. Otherwise, if you don't have any question. Yes. Presenters, kindly note your.
So the first one is if you have an experience with all those devices of radio frequencies, like body tight or Morpheus in using with brachyplasty, or J-plasma, the devices to tighten the skin.
I think that they do work in selected cases. Most of the cases I presented there were people with massive weight loss, where it's a waste of time. But a whole lot, and for example, if the excess is on the outer part of the arm here, then I will.
Thank you so much. The second question, okay, is. With patients at risk, maybe with a history of deficiencies, do you ever use some advice like zip?
They have dreadful skin, it doesn't contract, and so the risk of seroma is very high. The only thing that I do in some cases is these tailor tacking sutures, you know, to approximate. I usually just will tailor tack the sutures, maybe put a suture every 3 centimeters, and use them to take tension off the incision, you know. You know, when you have a sofa filled with a cushion with the buttons in it, it's going to pull their skin in like that, and it'll be like that for a few weeks. So I just tell them that. I think that's the...
There have been no other questions. Dr. Ndlamini requested to give us a... Oh, yes. You have a question? Certificates. Dr. Ndlamini requested to give us a report. The Society of KSPRAS
not have plastic surgeons currently, and we have such a backlog of patients waiting to be referred to South Africa or Mozambique. So they helped reduce procedures were fixing cleft lip and palates, fixing postburn contractures, excising keloids, and also doing a lot of breast reductions. Those are my 4.
I'm Kamundi. I'm a plastic surgeon based in Upper Hill, Nairobi. And I'm going to pass the mic to Dr. Wabwire to present the certificates to our presenters. And then we shall take a group photo. Come.
All the presenters kindly convene for a photo. Thank you so much for your patience. We don't take it for granted. So we're going to head out for lunch. We're going to give you 40 minutes. It's going to be held by the beach. Walk to the reception, take steps down, and you'll see some tents by the beach.
Shaban.
Hello, good afternoon. Welcome to Ortho Plastic. We'll not wait for the rest. We'll start off. We have one very ready presenter, Dr. Vaith, who's going to talk about, he's down in the program, okay? High resolution nerve ultrasounds. The importance of it. There's no affiliation. Dr. Vaith, maybe you can introduce yourself for 1 minute before you continue.
Thank you. Thank you very much for the possibility, giving me the possibility making my speech here and talking about the philosophy of treatment of peripheral nerves. My name is Veit Moser. I'm a plastic surgeon in Vienna. Since already 25 years I do peripheral nerve surgery, and I was happy and lucky enough to work together with Professor Hanno Milesi during his last years when he was the chief of the plastic surgery department. And so it kept me on going with much interest, and so I do a lot of nerve cases. I'm in the Trauma Hospital of Vienna responsible for nerve surgery and reconstructive surgery. And yes, that's short about myself. Please, could you have the first picture? So high-resolution nerve ultrasound as a diagnostic and planning tool in surgery management of rare chronic neurogenic pain syndromes. So chronic pain syndromes can be due to a nerve injury, can be due to neuroma, to nerve compression, or to scar-related nerve traction, and they may occur all over the body and are often not easy to detect. The surgical methods are nerve reconstruction, are resection of the neuroma, or neurectomy and relocation the stump into the muscle, and decompression or neurolysis. They are helpful and successful in many cases after conservative treatment. This presentation demonstrates how we use the high-resolution ultrasound imaging combined with a diagnostic nerve block to diagnose rare and atopic nerve-related pain syndromes, and how helpful this tool is in the planning of operative treatments. The ultrasound we use is a 24 megahertz based ultrasound machine the treatment or the diagnostics of the ultrasound is done by a very experienced radiologist. One of the co-authors, it's Professor Bodner from Vienna. What's the objective of the ultrasound? We can easily see in the ultrasound with a high resolution the diameter of the nerves and of the tissue. We can see compression, we can see swelling, we can see the impact of scars, we can see if the nerve luxates, especially on joints, and we can even see some of the structure of the fascicles. So the most important thing is that we can use it as a dynamic investigation. I will show you some clinical cases. A lady which had 17 operations on the knee, 2 times a replacement of the implant. Nobody was finding the reason for the nerves, for the pain. And we know that around the knee, the anatomy of the subcutaneous nerves is quite different. You can see in this picture many variations. With the new ultrasound, we can see that the nerves travel not always the same way, and we could find out which nerves were responsible for the problems. So pre-operative, we do a marking on the skin after, of course, testing and blocking the nerve, so that it's more easy to find and have a shorter time of operation. So we look for the nerves, we take out the neuromas, and we relocate the proximal stumps into the muscle. A second clinical case is a 70-year-old female patient who had a thyroidectomy. Some weeks after the surgery, there started the pain more on the right side, but also on the left side, which was worse when swallowing. She visited different doctors, she made different therapies, but nobody knew where the pain came from. So we made an ultrasound of the superficial nerves, and we found out that there were branches of the supraclavicular branch of the punctum nervosum of the nervus transversus colli, which were inside a scar. We made the blocks, and after successful blocks, we looked for the nerves before, and then we took out the nerves and relocated the proximal stump into the muscle. She was immediately after the treatment without any pain. The clinical case 3 was a 65-year-old female patient after thoracoscopy. After the thoracoscopy, she had an area of extreme electric pain. The pain medication was not successful. We found a neuroma of the intercostal nerve, which we blocked 2 times before. She was in a very bad condition, so no general anesthesia was possible, so we made it in local anesthesia with some sedation. Of course, we did the marking on the skin before. We took out the neuroma and relocated it in the muscle, and the latissimus dorsi muscle. And after the surgery, the pain was 0. She had, of course, some sensation deficit in the area of the sternum. So the next case is a young patient, which is a very sporty patient, which had a rupture of his Achilles tendon. And immediately after the surgery, he really had and suffered much pain. After removing the splint, after 6 weeks, we looked for the reason, and we found that there was a neuroma of the sural nerve. The treatment initially was done with minimal invasive. So we also made the block, we marked the skin, we found in the ultrasound, we could see that on the left side the dark structure is the vein, on the right side the nerve. Normally the nerve is not that big, but we could find that there was a suture within the nerve. So we went to the operation theater, looked for the nerve, and we really found what the ultrasound was showing us. You can see it in the middle of the picture, the nerve with the suture inside. So let me conclude. The high resolution ultrasound is readily available. It's a very inexpensive method at least the treatment. Of course, to purchase it's not that economic. It is a quick and high versatile tool to diagnose rare causes of nerve pain. There's no radiation, and it's a dynamic tool. It allows a precise visualization and localization. It allows to make precise nerve blocks and the ink or biomarking marking of the nerve branches up to a half millimeter. We see there are many advantages for the nerve surgeons and for the interventional radiologist for the treatment of neurogenous pain syndromes. So what we need to do before is we need 2 successful nerve blocks. We need a reduction of the nerve on the scale for at least 6 points. We can make the marking for the very small branches before, and postoperatively after the surgery it's very important to make a desensitization treatment and the training for the skin. So what will be the future? The development will be that we will have very, very small machines using at least the iPad or the handy for visualization. Up to now it's not with 24 megahertz, but only with 115. Thank you for your patience. Thank you.
Thank you very much, Keith. Thank you very much, and apologies that you are very interesting topic, you have to cut it short. We are limiting the time to 7 minutes. Thank you very much. I hope you'll be sitting back for...
if you have any questions, Dr. Goritz, who is also co-author and treating this, will... Okay.
Dr. Go will fight all the fires for him.
Yes.
Thank you very much.
And now, for those who joined us later, we moved a bit the schedule because he has a meeting, so we moved him up, Dr. Veith. So our next speaker is Yoa Aldabas, and she'll be talking about reconstruction of the knee extensor mechanism in complex post-traumatic soft tissue defects with composite ALT or CFL free flaps. Welcome.
Okay, hello. My name is Ola Aldabas. I'm from Vienna, and I'm very grateful to be here today to talk about my topic, the knee extensor, the reconstruction of the knee extensor mechanism in complex post-traumatic soft tissue defects. And I can't see the slides. There we go, yes. Okay, so the loss of the knee extensor mechanism combined with extensive soft tissue damage on the anterior side of the thigh pose a very functionally consequential reconstructive challenge of the lower extremity, especially then when the knee joint itself is also compromised, such as in trauma, infections, or multiple prior surgeries. So in complex cases, the standard techniques often fail, leaving patients with last options such as arthrodesis or even amputations. So in my case series of 3 patient cases, I want to show you that if you treat these patients as a single stage, in a single stage procedure, if you combine the knee extensor mechanism reconstruction with the joint salvage as well as the soft tissue coverage, you can reach a meaningful, you can restore meaningful function. So we have flaps that form the base of the reconstructive strategy. We have the anterolateral thigh flap, the ALT flap, with its long vascular pedicle. And we also have the TFL flap, the tensor fascia lap, with its broader myofascial block, as well as iliotibial tract, which is well suited for load-bearing reconstruction, but I will get into it a bit later. So we already have the patient number 1. It's a 27-year-old female. She had a severe motorcycle accident, suffered from multiple years of osteomyelitis, leading to finally to an arthrodesis of her knee. She came to us, she presented herself in Vienna with a fused knee, the leg was in full extension. She had an absent patella and her there was a severe discontinuity of her knee extensor mechanism. What was left was the tendon of the muscle of the quadriceps, partly. And she came with the wish of a transfemoral amputation and a prosthetic fitting. We managed to change her mind and discuss her case with the orthopedic surgeons that then went on and did a total knee arthroplasty. And in the same surgery, we decided to reconstruct the extensor mechanism. And we did that by choosing a TFL flap, which we chose based on the fact that we needed the iliotibial tract to bridge the gap of the knee extensor. So we took the TFL flap, we harvested the iliotibial tract with it, we went 10 centimeter beyond the skin paddle, and these are some intraoperative images. And to imagine it a bit better, here's an illustration of the strategy. So proximally you can see that we have interwoven the myofascial block of the TFL into the residual quadriceps muscles. This has to be done in, of course, full extension of the leg and under maximal tension. And then we draped over the flap and sew or fix the iliotibial tract, including the fascia, into the tibial tuberosity with 4 swivel locks, 2 medial and 2 lateral. It's important also to note that we didn't use flaps only for the purpose of soft tissue coverage, but we actually included it into the functional continuity, so it had a purpose as well. So this is a patient 19 months post-operatively, frontal and lateral view, as well as during active flexion and active extension. So she had an extension deficit of 35 degrees. She could achieve flexion to 110 without any aids. Here as well during active knee bend, and I have also a little video of her running. So it's safe to say she was happy that we didn't go through with her plan of an amputation and a prosthetic fitting. This is patient number 2. This is a soldier, 28 years old. You can see he had a near total quadriceps loss or destruction actually, with an extensive anterior soft tissue defect. So back home in Ukraine, where he was from, they already tried a free latissimustosis flap that unfortunately failed. He had multiple other procedures, nothing worked. So he came to us to Vienna with no active extension. He could slightly flex the knee. His knee joint was intact, so you might wonder why couldn't he extend, but it was because of all the fibrotic tissue, the adhesions, and also the chronic ulcerations around the knee. So what we did here in A, you can see the preoperative situation. Because he had a near total quadriceps destruction, the iliotibial tract wouldn't have been enough to reconstruct that or to bridge the gap. So in his case, we had to use a polyester mesh, like a Lars band, at least this is what we call it. And we did it the same way we did it with patient number 1, proximally interwoven into the quadriceps muscle, and then pushed or pulled distally in full extension and maximal strength, and fixed it into the patella this time, because he had a knee joint, with interosseous holes. So this is what you can see in, especially in image D. You can see the Lars band, the polyester mesh, and then the flap of choice was an ALT flap, including the fascia, which we then draped over the synthetic construct. So also important to use the fascia, because we do need a biological environment to cover these synthetic constructs, and flexion he was able to do to 120, and he actually went back to military service. Now last patient is a soldier, 22 years old. He had a history of grenade injury as well. The left leg was an above knee amputation. The right one he came to find a solution for. He had a knee arthrodesis priorly done. So with him, we also chose to use a Lars band, because the extensor, the bridge, the gap that we had to bridge was way too large. So we did that. The choice of flap was an ALT flap. He also did get a total knee arthroplasty via the orthopedic surgeons. And here also you can see the synthetic ligament with the flap draped over. 1 second. Yes, that was him during rehabilitation, and also him be ambulated without any help, except of course the prosthesis on the other leg. And this is also him during an examination. And yes, so basically the only thing that is important is to see everything as one problem, one issue. You have to see all three components. You have to deal with them in one surgery, because you cannot, it will cost you tissue qualities, which you cannot get back. So more surgeries means more tissue loss, more scarring, more infection risk. And it's always important to use vascularized fascia as well, because it retains its own blood supply, which means in the knee, where it's also very critical, it's important to maintain the natural gliding. You know, it has to move with every degree of flexion. And yes, so even at the extreme end of reconstructive surgery, you can restore a fully functional limb again. Thank you.
Thank you very much for your presentation. Professor Seguapa, are you around? Yeah, please come. You are the next presenter. Unconventional ways of treating nitric acid burns. We don't see this much in Kenya. First of all, you'll start telling us where do you get nitric acid and what do you do with it.
Yeah, sure. Thank you very much. Thank you.
When I knew him, he was a slim young man.
Hi, good afternoon, colleagues. Thank you very much for inviting me, Professor Nangola, and the team. Actually, this is one of the two cases I've seen in my career, and I decided to treat it the way I will tell you now. We can continue with the slides. Which one is? Can you? Okay. Can you put up the slides before the red light goes on and the bell? Okay. All right, I'm not going to go through the objectives because of time. Nitric acid really are very rare. I've searched the literature. Most of the acid, chemical burns that we see are actually most of the other acids. Nitric acids are actually very rare in our country and also worldwide. In the literature, I could get only less than 20 of those cases that are reported in the literature. So I'm just going to run through the slides so that time is not against us. So in South Africa, chemical burns account for 3 to 5% of all burns, but sulfuric acid dominates those, and nitric acid is, like I said, less than 20 in the world. I'm not going to go through the pathophysiology, but what happens is there is a distinct color that it leaves once you have that kind of burn, that the process that goes like a xanthoprotic reaction, where you get a yellowish brown staining and discoloration. So when I saw this patient, it was a referral from another hospital. So I saw the patient, I think, within 24 hours of the burn. And then I decided, look, normally what we do, we leave a chemical burn to delay itself, and then debride the eschar, maybe graft at a later stage. So what I did, this is a 34-year-old male that came to me, presented with 38 hours post-injury. There was no inhalation injury, and there was no systemic toxicity. It was adequately irrigated at pre-hospital where he comes from, and the local wound was clean, and the patient was stable on admission. This is how we conventionally treat acid burns. We leave them, they demarcate, we then debride and then graft. So what I did here, I did early tangential excision using Vesajet, which is hydro system, and then I dressed it with a biosynthetic scaffold, BioBrain, and then the dressing where I dressed over with Acticoat Flex 3, which I leave for 3 days. So there was less pain, and then I reviewed the patient on, after 5 days. So this is the patient preoperatively when they came into the ED. They had erythema, the wound demarcated well, there was no systemic toxicity. This is day 2 in the ward. That yellow color is coming out. Took them to theater. I normally pre-wash with chlorhexidine before I start. And then in theater, I debrided with Vesajet. Then you get nice punctured bleeding, dressed with the BioBrain, then Acticoat Flex 3. Patient was discharged the following day, reviewed after 5 days. You can see it's adhering nicely. The black color there is the Acticoat. And then this is him after about 10 to 14 days, discharged everything. Postoperatively, no pain, minimal discharge, minimal infection, discharged home, and then, right, so this then led me to propose a conventional management. You have the resources like VesaJet, Ectricode, and BioBrain, then you can use this modality. Right, so the results were complete epithelialization, and then in 10 days, no infection, no grafting necessary, and there was no hypertrophic scarring. Patient discharged within 10 days, excellent cosmetic and functional results. Right, this I will skip. So basically the discussion is conventional nitric acid burn management, we normally delays. So with this one, if you have the resources, like I say, early tangential excision with a VesaJet, you then put a temporary dermal substitute, Ectricode, and then within few days they heal very nicely. Right, so key take home, nitric acid burns are rare globally and in South Africa. Traditionally we are very conservative, but I decided to do early debridement with BioBrain and Ectricode. So this can guide how we approach burns, provided we have these resources. If you get this kind of burns early, you can actually avoid grafting. Right, these are my references, and then I would like you to watch this video to the end, and thank you very much. Can we have volunteers? And join us in Berlin next year.
Thank you so much, Professor Segwapa. We have learned a lot from that, and now we are ready to manage the same if we come across it. So the next speakers are the two Peters, and it happens that one of the Peter, Dr. Peter Odor, is my teacher and my mentor from Nakuru, and they'll be discussing development of post-burn contractures and associated disability in a resource-limited setting, insights from a surgical reconstruction mission. Welcome.
Hello, good afternoon. Thank you for the intro, Doc. I'm Dr. Mugo Peter, and I'm here to present some work that we conducted alongside another mentor, another mentee, Dr. Peter Odor, Professor Peter Odor, about a subject that is familiar to all of us, contractures. So I'm sure we are all familiar with contractures, the risks, and how you manage them. But today I'd like us to look at it from the insight of people who have already developed contractures, and then we analyze what are the factors that led to its development, and also we tell the story of how do these contractures affect them on a daily basis. So this is a study that was conducted in a surgical camp in Kisumu that was for patients who had developed post-burn contractures. They were admitted for surgical release. So just for a bit of a background, we are all familiar as a major complication of burns, and as we all know that burns are a major problem in low and middle income countries such as in our country, and therefore the part ability that often affects people with burns is the development of contractures. This comes in the form of limitations, physically pain, limited ability to perform activities of daily living, which also affects their productivity. Then mentally, depression and anxiety are major concerns. And of course, so this was a retrospective observational study. We studied patients who had already developed contractures. Now, we involved only those who had developed specifically post-burn contractures. Now, besides just characteristics that we used is what is highlighted in that slide, disability adjusted life years. So this is how this goes. There's a study that was conducted by a global burden for disease. It was a study conducted by think tank from the University of Washington, and we basically try to assess how do certain diseases affect you in terms of your functionality and your day-to-day living, and they give a disability burden to each condition. For post-burn contractures, it's 0.5. So the formula highlighted in red is how you calculate disability adjusted life years. So in short, it's called a DALI. So one DALI means 1 year lost due to disability. That is the formula, most of whom were female. And of course, there were about 48% of them were male. The age was, we assessed relatively young people. The youngest around 0.8 years, and the oldest was 36. So this was, I'd like you to put in mind that this was a cohort of fairly young people as we talk about the disability. Then most of them got the burns due to scald. The mechanism was scald majorly, and a few of them were flame. Then the duration for which they had lived with the contractures before they presented for release, the average was 3 years. The least was about 0.5 years, and the most was 12 years. Then the chart on the right part of the screen highlights the areas of the body that were affected by contractures. I'd just like you to note that the most affected region was the upper limb, hand, elbow, and the wrist. Then so here are the risk factors that contributed to patient developing contractures. One, a good number of them, a third of the cohort, did not seek any form of medical intervention after they sustained the injury. Then for those who did seek intervention, I'd like you to note that the level of facilities they received care was level 2, level 3, level 2 to level 4. That is what, level 4 is what you consider a sub-county hospital, a district hospital by the metrics of Kitambo. And typically at that level you might not find someone who is a dedicated burn specialist. Then on the other aspect, for when they did receive care, they did not receive, 95% of them were admitted to hospital just purely for wound cleaning and dressing. No surgical intervention in the form of skin grafting or rescue was done. Only 5% received that care. Then based on the formula that I had highlighted earlier, we observed that the cohort of 106 people, collectively they lost 163 years, disability adjusted life years, due to the contractures, and that was an average of 1.54 years, or 1.5 years for every person who had a contracture. Now, this the graph here highlights that the major things that contributed to people getting contractures. One, it was about the systemic factors. As I highlighted in this chart here, most of them were managed in level 2 to level 4 facilities where we do not have dedicated personnel who are skilled in providing care to people with burns. As a result, that contributed to them getting contractures. So ineffective referral is the main area, is one of the factors. Then in terms of, for those who are indeed treated in those facilities, the care was inadequate in that there was no surgical intervention, and also there was no adequate rehabilitation. What we typically offer in the form of splinting, physiotherapy, that was not offered. And that was a major gap that contributed to this problem. In terms of patient factors, as I highlighted, a third of them did not seek healthcare services. This is also a problem noted in other low and middle income countries by a similar study. And the major factor there, of course, is finances, financial limitations, which affect the health seeking behavior. Now, I'd like you to note that the disability was a major problem for the people who are living with contractures. One, you note that our cohort is fairly young people. That means their growth and development was affected. At the same time, the upper limb was the most affected region of the body. We understand that the upper limb is very important for fine motor skills as well as performing activities of daily living. This highlights the burden that these contractures imposed on our cohort. At the same time, as I highlighted earlier, every individual lost about 1.5 healthy years because of living with a contracture. So contractures are not merely just another complication of burns. They do indeed have an impact and on the outcomes. And what you can conclude for this is you just need to be aware of the systemic treatment and patient factors which contribute to the problem of contractures in our care, in the care of burn patients. Action points. One, prompt referral for patients who have deep burns, especially, let's say, your second degree deep burns and above, which heal with extensive scarring and So at the same time, the need for appropriate surgical interventions and then comprehensive rehabilitation services are needed. It's a major gap in our setup. Then more studies, of course, are needed. This was a study that just highlighted highlighted to us that we are indeed having major gaps. But how many times do we audit most of the patients that we do manage in our burn settings to see how the outcomes are? So of course there's need for more studies to assess our burn care and then assess the quality of life for people who are living with contractures. No conflict of interest to declare. Thank you for your audience.
Thank you very much. I know you have said more studies are needed, but thank you for starting the studies. Their next presenter is Dr. Alvis, talking about regeneration in burn surgery. EV-enriched lipofilling as opposed to amniotic. Please give us this new technology.
Yes, this is working. Okay. Here we are. So yeah, I'm showing you. I will show you the protocol you use in Padova to treat our burns regarding regenerative surgery. So let's see. Is going on? Yes. So a crucial topic in regenerative burn surgery is that we have to understand that the main topic that is not just to cover and revitalize the burn, but you have to think about the skin quality, the scar quality, both from an aesthetic and a functional point of view, to think how the skin will behave with the growth of the patient in case of a child like this. And also, don't forget the donor side that is often underestimated by surgeons, but can become a really problematic part. So for superficial burns, second degree, human amniotic membrane is quite well studied, a good resource. It's very well known its effect on pain reduction, and in our environment is also a very cost-effective resource. We rely on a tissue bank, okay, that within few hours can bring us the amniotic membrane, perfect traceability, okay. And you see in the last 5-6 years, we operated more than 500 patients with quite good result. I'm going to show you someone. This, for example, is a young child, second-degree burn on the face and the shoulder. This is after 1 week that we applied the amniotic membrane. You can see on the forehead that is drying up a bit. And after 2 weeks, almost completely healed. Another case, second degree on the chest. You see, we use usually the the frozen amniotic, not the dried one, because we like to keep like the layer that can cover the burn. Then we put some stitches that we removed after usually 1 week, 10 days, without leaving any scar. And you see after 2 weeks, completely revitalized. Then, of course, when the burn is more deep, we have to resort to like a dermal substitute. We've got many different ones, and I'm going to show you some of them, keeping in mind that, of course, there is a compromise when you use a dermal substitute, because it's going to take more time before we get to put a skin graft, like between 2 and 4 weeks at least. But of course, they give us a better scar quality, and especially if this is involving the joint. One of the most used, most well-studied, most historic one is Integra. Very good one. I would say that is for all season. Of course, very well studied as well. But of course, it takes a bit of time, like from 3 to 4 weeks. But it's the one that I would say you never fail with Integra. Another one, if you Matriderm, this is rich in elastin, so is really indicated if you have to cover some joint, like some exposed tendons, because the elastin give more pliability, more elasticity, and give a better result on the joint. So it's our first choice when you have to cover joints. And another one, Pelnac, which is a telocollagen, so super processed collagen. And this came with some holes in it, like a net. And this is very useful if you have to put in some wounds that you're not sure about the exudate management, or you're not too sure is well clean, dirty wounds, because it can help a lot. So it's our first choice in like dirty wounds or in wounds that we have to manage the exudation. Donor site, as I told before, is not to be forgotten because it's a second wound, and sometimes can lead to a lot of problems, a lot of chronic pain, pigmentation issues, or hypertrophic scar or keloids. And our first choice here could be the fish skin. This is a product, KSPRAS, it came from Iceland, from the skin of the cod. And we know it's very rich in omega-3 fatty acids, and it's very well known the pain modulation effect, and also their effect, the modulation on inflammation. This is a chronic wound on a donor site, more than 6 months going on, and with a single application of KSPRAS, after just 30 days, we achieved a complete revitalization. So they are very, very good. Of course, it's not the only option. In children, we usually use amniotic membrane as well. Or there are some other options, like this is a Supratel, is an epidermal substitute that you can just put on it and remove it when it's completely revitalized, the skin. So this is a bit of a scheme of our algorithm regarding the dermal substitute. Then you can see for, depending on the wound depth, the contamination or the exudation management, the anatomy, the need to cover a joint, we can resort to a specific one. Then this is the final part about lipofilling. We know lipofilling is very, very used, especially in the outcomes of burns. So both for the filling effect, to restore a bit of volume in adherent or retractive scar, both for the stem cell we're going to put with a fat graft that is going to regenerate the tissue and the area. When we usually prepare, with the sedimentation by gravity, the lipoaspirate, there's a part we always discard, almost everyone discard, which is the infranatant fluid fraction, the part below. We just keep the golden part, the gold part above. So we thought, but what about, now there's a lot of talking about the exosome. What about if this part that we are discarding is actually rich in exosome? So we designed this study. I'm not going too deep because I'm already in the last minutes, but with many imagings, we are like assessing those vesicles to see if they are exosome, and also to evaluate the effect on a culture of human fibroblasts. And not surprising, actually, we saw that, you see, in red, the infranantact part is actually the part more richer in exosome. So we define then, okay, that to be sure they are exosome. We try a vitality test on the culture of fibroblasts. They survived, but they were actually a pro-survival effect on the culture. And then we saw our effect on the expression of genes, a cluster of genes like this one, like SIRT1, EP, subcutaneous tissue, and the infranatant part with very fine needles in the dermal part, okay, to get, so the filling part in the subcutaneous part, and just finish, it's the last one, and the regenerative effect of the exosome just in the dermis. This is the case, okay, you see after just one injection. Of course it takes time, but we get a complete revitalization at the 12-month follow-up, with also recuperates a lot the extension of the joint. So this is just to think about that not all the waste is to be thrown away. Thank you very much.
Thank you so much, Dr. Alvis, for that. So our next presenter is Dr. Victoria, and she'll be talking on high voltage electrical injuries. Is she here? No? All right. So we already had Dr. Vaith giving us a talk, and we have come to the last part of our presenters. The master class won't be happening, but instead we have two presenters, and that is Helen. Is she around? Helen will be giving us a very interesting talk. I'll let her introduce it, and then we'll call the next speaker. Thank you.
Thank you so much. Good afternoon. My name is Helen. I'm a critical care nurse from Kenyatta National Hospital, and I would like to talk, I'll focus today on three important issues. Behold the burn. Behold the burn, there are three important aspects of burn management, and that is nutrition, okay, that is nutrition and psychological impact of burn injury, and then the referral and transfer of burns. After this presentation, I would want us to appreciate
understand the requirement of bands, the impact, and the principles guiding the referral and transfer. As you all know that after a large burn injury, there is hypermetabolic and catabolism that increases the energy expenditure, and therefore the burns requires an additional or substantially a high nutritional requirement than normal. Large burns, and especially the burns of face, they are not, after those burns, the oral intake is impossible, so the enteral feeding is required. And especially when we have burns of face, hands, and inhalation, it complicates the nutritional requirement. This illustrates an nasogastric tube as a route of enteral feeds, and it is a practical route, especially when the gut is functional. And the choice of enteral feeds depends on condition of the patient, aspiration risk, and the expected duration of nutritional support. These are the factors that increases the nutritional requirement: the age of the patient, the total surface area, and the condition of the patient that is expressed by temperature, ventilation, and so on. A patient with burns, extensive burns, they will tend, because of hypermetabolism, they will tend to use their muscle the protein mass instead of the muscle mass, which will lead to low weight and impairment of the wound healing. When the oral intake is applicable, these are some of the high-dense nutrient food. However, when there is extensive burns, oral intake is not very necessary, but then the nutritional support will be required. And then now you've seen about the physiological aspect of burns, and now because burns are high metabolic rate of burns is psychological, but then the wound is not finished just by a closure. It will also need psychological support of these patients. Burn scars are very traumatic, and they change the appearance of the body, and a patient will experience a low self-esteem, and the burns that occurred even in teenage age, the scars will continue even at adulthood. And this will interfere with the relationship, going back to work, going back to employment, and workplace, and even school. And this will even cause some conditions, including but not limited to post-traumatic disorder. And some of these patients will not even be compliant to treatment and rehabilitation, especially alignment of contractures, as we have been saying. So beyond this, we need to consider if the patient is in pain, fear, psychological stress, so that we do not label them as non-compliant. And some of these patients, before going home, they will need to be placed, or going back to their pre-burn state, they will need to be placed in high-level cares, and especially the elderly, because when they go back home with those contractures and those scars, the self-esteem is very low, and sometimes they will not be even welcomed back to the society. And then now we move to burn referral and interfacility transfer. And the questions we are supposed to ask ourselves is, who are these patients who need critical care of burns, and the factors affecting safe transfer, and how transfer is done, and then the documentation of the information that is supposed to accompany the patient when we are having transfer. These are the criteria of burns, as the doctor has already said. We have 10% burns, and even the full thickness burns of special areas, hands and joints and feet because of function, perineum because it's a specialized area, circumferential burns because of respiratory and vascular impairment, and burns of inhalation because of airway impairment. There are some other mechanisms of burns that increase the need for referral, electrical burns and chemical burns, because what we see on the surface is not what is real after the burns are assessed. And this is inhalational burn, the need for referral, the facial burns because of communication, and we have said the airway. And these are the urban. There's a little difference between urban and rural transfer, because in rural transfer you have to do the secondary, you stabilize the patient, and then you transfer the patient. These are, the patient can be referred by ground or air, but what we are saying, this is the checklist of when you are transferring the patient. If the respiratory is compromised, you stabilize, maybe intubation, circulatory, you resuscitate via the IV. If urinary catheter is indicated, you cover the burns because of hypothermia, narcotics you give, and then decompression, GI decompression, and then prophylaxis of tetanus. And what we are saying, these are the things that you have accompanied the patient with, the medication, the full note, and then the images. What we are saying in a nutshell is survival, recovery, and then quality of life. Thank you.
Thank you very much. It is difficult to summarize everything in burns in a very short time. Thank you very much. This session actually was supposed to be a masterclass about burn prevention in Kenya, and the presenter was supposed to be Dr. Kahoro. Dr. Kahoro has been a long-time, she was a founder of the Burn Society of Kenya, and we've been working very hard in burn prevention. One of the things that we worked on in burn prevention is multi-sectoral collaboration in prevention of burns. We went together with the other stakeholders in Kenya to try and promote burn prevention in Kenya. These are firefighters, ambulance people, and all other stakeholders. And our last presenter is a person who has been in this team. He's been very, very active in this team of prevention. He's a firefighter, he's a community mobilizer, and he's a fire survivor. And he's really worked hard in this prevention of burns within Kenya. A very good friend of ours, a very good of BSK, a very good friend of mine. Please welcome Jose to come and give us our final presentation for today. Jose. You can use that one there.
Thank you for having me. My name is Jose Njoke Emo Ngonjiri. We shall play a video. That's part of my 5 minutes. Okay, thanks. Those ones, we call them street theaters. We go to the community right on the ground and teach them on how to control fires that are involving gas cylinders, how to escape from homes. My slides, please. I hope I'll make it in 5 minutes. My 1 minute is going. There you go. My name is Jose Njoke Ngonjiri. I'm a fire safety officer, a burn survivor, and a prevention advocate. I'm actually a firefighter by profession. This was an interview after guys, the fire chief saw my hand and he was like, hey, how will you be able to hold a fire hose and you don't have a hand? So I was like, I don't have a hand. I have a hand, it's just fingers that I don't have. And out of this, I got my job. 46 years ago, I got burns, and my house left me in a house and went to pick up my older sister. On coming back, all our house was on fire. And I sustained 3rd-degree burns on my face and on my hands. I had contractures, and throughout my ears, I've been going through surgeries. And in that house fire, it's only me and this food flask that remained. This food flask is 47 years old. I'm 46 years old. So it's interesting. And, thank you. When I was 32 years old, I went for, what do we call it? I went to test my car to see if it was working. And lo and behold, there was proof that my car is working. Yeah, he's 15 years old now, and I thank God for that. At least, not only lost, my fingers are lost, but down there everything is cool. Prevention is better than cure. And what happens, you'd rather prevent these fires from happening than when we go to the surgery room. Is that true? So, because you can imagine the pain that I went through when I was 4 months old. Yeah? The 9 months of every day in the hospital. You can only imagine that. The countless of surgeries. I remember at one point, that time it was Operation Smile. I had to go to crazy, painful surgeries. Yeah, in fact, just recently I'm just saving for some cash to go for another last surgery to see how things are going to go. Also, you get scars, and which are traumatizing, and of course the long-term impact. So you'd rather do prevention. There's the awareness that you saw in the videos. Therefore, we create safe homes, we create safe kitchens, safe communities, and guess what? Lives are protected and dreams. So BSK, we've been doing a lot of stuff, and part of it is us guys at Africa Fire Mission got to partner with BSK, and we have people like EPRA, Energy Petroleum Regulatory Authority. We have plastic surgeons. We have youth champions on the ground that we train to get to do the work. By the way, for your information, even as I'm here today, on the ground, they are working. So we encourage gas cylinder safety. We go to schools to teach them school evacuation drills. As you've seen in Kenya, we have about more than 52 schools that got burnt. So we got to train them on how to evacuate safely. And then also we train the youths. And we have community resilience groups. How after the fires, how do they get to come up back again? Prevention matters because, of course, the pain, the surgery, there's a loss of school time, financial burden on the community, and also in the doctors and family. There's emotional trauma and lifelong scars. You can see my face. So just imagine my dating life, how it was. You know, how many rejections I've gotten. Oh, by the way, this weekend, tomorrow, is it tomorrow, Saturday? Saturday I'm officiating. I'm actually going to have a wedding. Yes. So I think they saw my profile. They were like, Yaitani Peter, this one will not pass me. I have to get this dude. Yeah. What can we do together? We need to strengthen prevention education. No matter what we do, yes, you're a scientist and a doctor, we have to do the prevention education. We have to support burn survivors. We have to promote safe homes and kitchens, improve gas awareness. We partner with other firefighters and other stakeholders, and guess what? You listen to survivors like myself. And that's it. Wow, I'm done. Thank you.
Wow, that's an amazing way to end the session. It's quite a nice talk, and we commend the work you're doing. It's true, we need to prevent. It's better than the management. Thank you to all the speakers. So I'd like to open the floor to question and answers. I like that we've kept time, so we have a bit of time to ask the questions. Any question? You can have your... Yeah. And also, can the speakers come up as we have the audience ask some questions? Any question? Is it that
can I
you
start
ate too
by
much?
Asking Jose? Jose, as BSK, we worked so hard in elimination of the paraffin stove, and we were caught somewhere with politics and everything, and we handed over to some of you. Where are we now with the paraffin stove? We wanted to eliminate it from Kenya because it was cause of the big fires. Where are we now with the paraffin stove?
Paraffin stove has been replaced by gas cylinders, the new menace. And now the challenge with gas cylinders is that we're having unscrupulous dealers who refill these cylinders in their back rooms and backyards, and they are causing a lot of mayhem. So we are partnering with EPRA to go and arrest these people. And the challenge we are having is that, unfortunately, these unscrupulous dealers they're really liquid and they're well connected on the ground. But if that is eliminated, we're sure going to save a lot of lives. So the kerosines are over. There's no kerosines, but now it has shifted to gas cylinders.
Thank you very much. Any other question? Professor Nangole.
Thank you. My question is on the issue of the ultrasound. I don't know. It was Andrea. Yeah, I think the ultrasound in hand surgery seems to be gaining a lot of popularity in many conferences. There's a lot of emphasis. So my question is, how long do you think a plastic surgeon, like most of us here who do not have basic training in ultrasonography, will take to be good enough in using the ultrasound in day-to-day diagnosis of nerve-related problems? Then my second question is on the extensor mechanism that she presented, which was very good. What are your thoughts on using a chimeric flap, for example, the LT with part of like vastus lateralis or rectus femoris, and use the muscle to reconstruct the tendon, as opposed to what you presented, which I think also you gave very, very good results. And then finally to Helen. Helen, you presented very well on nutrition in burns and so many. My experience has been, if there's an area where I feel we do not do well, is in nutrition management of our burns patients. And most of us who've worked in the burns unit, you will testify that most of the time, more often than not, is the nutritional assessment and monitoring of our burns patient is most of the time below expectation. In fact, whenever you ask in a ward round what is the weight, what was the weight of this child, everybody turns around. And therefore, from your own point of view, and I know you've worked quite for some time in the burns unit, where do you think, where is the problem? Is it an attitude problem, or is it that we do not understand the role of nutrition in the care of these patients? Thank you.
I think we'll take the questions first of all. I think you should be there. Questions before we...
My question is to the presenter on the extensor mechanism. What is the rehabilitation protocol that they use in the institution to obtain that very much good results?
Any other questions before we give to the audience? Where? Okay, go ahead. Who wants to start? Go ahead.
Hello? Yes. Thank you very much for that very practical question. I think as plastic surgeons, we can train every day with the ultrasound and we can get better. And there are very good books that for each superficial nerve, you get landmarks, anatomic landmarks, and we know the anatomy and we also know the intraoperative anatomy. And I think we can quite quickly learn to adapt to this different view. However, there are some things that really need a lot of training and also expertise, and therefore I would say it's also good if you can cooperate with a radiologist. But I think every plastic or hand surgeon can learn how to use ultrasound. So you start with just seeing seroma and seeing foreign bodies, which is really easy because you know where the problem is. You put the probe on it, you see that there's something wrong or something, and so you can quickly, every day, you can become a little better. And it's very helpful. It helps you in so many situations, and it's also very instructive for the patients. They love it when you can explain what they have and you can see it on the screen. Oh, is that a good answer? Yeah.
Thank you, Professor, because of the question of the nutrition. Beyond the attitude, nutrition is very important in burns unit, in burns patient, because it's not only the weight, but even the blood sugar has to be taken. Sometimes the patient come as an emergency in burns unit, and they have been burnt beyond 50%, 70%, even 90% burns. And the first thing you think is just to place that patient in the bed and start the acute resuscitation of IV fluids. And I think in that time, the weight becomes sometimes difficult even to take for these bedridden and intubated patients. But for the patient who are walking really and they have low percent burns, and for the children, we have to take weight, we have to take blood sugar, BPs. Those are very important in nutrition, so that we can even know the requirement, because the larger the burn, the greater the nutritional metabolic demand, and the nutrition demand also goes high. So it is upon us, when these patients come to us, we take good care, and we remember nutrition is all about the burns, because if the patient is having this hypermetabolic and catabolism, and if the nutritional requirements are not met, it will lead to low weight, and then even that burn will be difficult to heal and it will be impaired. So Sometimes it is attitude, yes, and sometimes when these burns patients come with high percent burns and they are just bedridden, they are in the bed, we maybe have to look for a way of taking their weight. Yeah.
Thank you, Professor Ngola, for the question of yours. So for the chimeric flaps, you can absolutely use them as well. So it all depends on the defect, where it is, and how extensive it is. You can also use the ALT flap if you want to make it based on the vascular pedicle, but you can also, of course, shape it in a way that you would also add the iliotibial tract. It all works. So we had a patient as well where we did it in a similar way, because the defect size and orientation are not supposed to put any load on it or any weight on it, and then they can slowly start after maybe 4 to 6 weeks to slowly put weight on it, and with the physiotherapist to start, loading on it. Only because synthetic ligament, we're scared that it might rupture. If you don't use it, you might even start earlier, but this is how we usually do it.
Sorry, I've realized that Professor Ken Seguapa, no one is asking him a question, so I'm going to ask him one. Now, for a long time, chemical burns have not been common in Kenya. Maybe you see 1 or 2, but this year there's been an unprecedented increase in the same. Yeah, I agree that it's very, in the initial presentation, it can be very difficult to tell in our skin type how far the skin is involved, and waiting a little bit helps. But I wanted to ask is, I don't know whether you have, I know for example in India, there's the use of diphoterin as an initial neutralizing agent, and even industries have been asked to stock it for industry-related exposures. I don't know whether you have it in South Africa and whether you get industry-related chemical injuries. And then the other thing was the average graft take on such wounds is usually, again from observation, not good compared to just a thermoburn. So you tend to either have to regraft or to struggle with the tick. I don't know whether the experience is similar to that, and whether there are strategies you use to go around that issue.
Yeah, thank you for your question. The chemical burns we see are industrial, and mostly they are assault, especially with battery acid. The nitric ones we don't see. I agree with you, the graft take, you need to prepare your bed properly. If you go and debride for the first time, remember this is a continuous process. If you debride once and you graft, chances are your graft, you might lose it. So I prefer to graft, wait, and then in 48 hours, relook at the wound bed. Once I've prepared the then I find it takes quite well. What was your other question, Dr. What we use, we don't have it. We wash them with water copiously, except for the fluoroacids, those are exothermic. You'll make the burn worse. So, but we especially with this nitric acid one, which actually in my life, I've seen 2. One patient I treated, he never came back. This one is the one who came back. So I don't have results on that one. We give them sulfadiazine to apply this, and then it demarcates, and then you debride and graft. So we don't have that agent that you're talking about back home. Thank you.
All right, so we've come to the end of the session. Thank you so much for participation, and to the speakers, that was amazing. I think we will stay back for a picture, and then I will hand over back to the organizers for any announcements. I know for sure one announcement that has been given is that the organizers did a very good job to bring together sponsors and medical companies and pharmaceuticals. They've done a very nice setup outside, and they have very nice products. The request is that now that we are done with the session, please take time to go there and interact with them. There's quite a lot you can learn, and also just be aware is in the market. So the presenters, we are about to present you with the certificates, and the photographer, you'll be ready to take. Okay.
Certificates. She's surprised. Yeah. Jose. Okay. Alvis is next. Yeah, it's okay, no problem. Somebody else. The third one. Jose. We'll give you another. Dabas. Okay. Faith and orientative. Professor Ken. Something from Christine.
No.
Can give the handshake.
Yes, so after this we have a special program also for the residence ball. Dr. Josie is in charge of that. Dr. Doi, sorry. Doi. Oh my gosh, sorry. I don't know, do you want to talk about it? And then we'll have the cocktail. Latismas Dosa.
Hi everyone. So this year we wanted to have a residents bowl, just a small friendly competition for the residents to participate in. We divided them into 4 groups, 3 people each, and we've gotten a cash prize only for the winning team this time. But next year we will work on getting prizes for all the participants. So we're currently still setting up. So I think there is some tea and snacks that has been set up in the exhibitors area. I think we would like the members to go and have some tea, and then maybe in about 20 minutes we can reconvene back. Then we'll have competition, and then we can proceed to for the cocktail after. Thank you.
Team 4 came in with 40 points. Unfortunately. So Team 4, unfortunately, will not proceed. Maybe next time. But thank you so much. It was a great sport. All right, so we'll move on to the next stage, which we're calling the Blitz round. We will project images. Each image will show for about 5 seconds. Each team has papers and a notepad and the questions for each. So for the first one, name the nerve and the hand deformity name the nerve and the hand deformity that occurs when it's injured. Describe the 3 types of. Okay. Next. What? Why do we? Okay, pause, please. What is this? All right. We'll start from slide number 2.
Number 2. Next.
Describe the 3 types of perforators that have been shown. Name the flap. It will come. This is your turn to relax.
We need you, you know, as always, the resident is the one who knows. Yeah. The game is over, please stop writing. We'll now go slowly through the slides. So, question 1 was the nerve. It was and the deformity was claw hand. So, unfortunately, group 2, you didn't know the deformity. Question 2, famous question, describe the 3 types of perforator flaps. Myocutaneous, septocutaneous, and musculocutaneous rather, and then direct cutaneous. All of you are passing. Good. And name the flap. We thought you would use the names that are there to know which type, which body part this is. Some of you said the ALT flap. Actually, none of you knew that that was the abdomen, but yep. Not this one, the previous one. The previous one. This one. Plastic surgeons should think on their toes. That's why it takes long to raise flaps. I'm kidding. At least this one, all of you knew it was the LT flap. Next, diagnose the condition. That was cleft lip. Next was Poland syndrome. Next was a Burns, congenital amniotic Burns. Next, at least everyone knew, it was microsurgery. Next, name the procedure. It was blepharoplasty. The underdogs. You've not been attending the lectures on aesthetics. Next. I thought you could see the nipple, but it's fine. This was a breast reduction. And actually, yes, they saw it. Which class are you guys attending? Unfortunately, the projection made it hazy. Anyway.
So from round 2, group 1 got 30 points. Group 2 got 45 points. And group 3 got 35 points. So we're proceeding with group 2 and group 3 into our final question and answer round.
Clap for them as they came in first, but at least they didn't leave last.
So for our last round, it's a question and answer round. You each have the app with the buzzer. So whoever presses the buzzer first will answer the question.
What's the code? We didn't need to buy a buzzer, so it saved us a lot of money. So we used an app with the era of AI. Are we ready? There's 50,000 on the line. Are we ready? Okay. Please project the question. Don't go to the next slide. Okay, if you don't know this, what ancient Indian text written around 600 BC is widely considered? Who was buzzed? This was the first slide by Prof. Makatha. Which group?
The Sushruta Samhita.
Correct. Please clap for her. It's asking for the code again. Okay, so to change this game, just raise up your hand. Please keep it down. Okay, who's known as the father of modern plastic surgery? Group 2.
Sir Harold Gillis.
Prof. Makatha would have been embarrassed. Next year. Yes, you're correct. Sir Harold Gillis. What is the literal translation? Next. The answer is To mold or to form? Are you taking? Okay. Okay, round 2, anatomical terms and concepts. Next, in reconstructive surgery. Okay, you will help me choose who rose them. Okay, answer.
An axial flap depends on a named vessel, while a random flap does not have a named vessel.
Correct. Next, you can show the answer. Next question. No. Please, raise your hand.
It's okay. So deep inferior epigastric perforator flap.
Okay. Next, for the answer. Next slide there. Please answer.
A dermatome and army knife.
You have to pick one. It's written what standard medical tool?
Dermatome.
Clap for him. Use the mic. Give the mic. Give the mic over.
The superficial muscular aponeurotic system.
Correct. Please clap for her. Next question is surely.
Cleft lip.
Clap for her. Who raised the question? Which one? 2 hands have said you, and 1 hand has said her. Okay. Group 3. Who raised the hand? Group 3? Say aye. Group 2?
Autologous cartilage flap. Graft, sorry. Autologous cartilage.
Let's see if he's correct. And the answer is surely. If you're wrong, you're subtracted actually, so please be sure. -10. Read the question next. That's it? Okay.
Syndactyly.
And the answer is clap for her. Trauma and micro.
Operating microscope.
Are you sure? Do you want to change your answer? If you get it wrong, you'll miss. And oh, sorry, what's the answer? You're correct. Yeah, the operating microscope was invented, yeah. I feel like Kimutai, you keep raising your hand while you're reading the question.
Implantation.
Uh-huh. You're correct. That side? Okay. Group 2.
Tendon transfer.
You sure? It's -10 marks. Are you sure? Are you sure? Going once. Going twice. Have you read the question? Oh, okay. You sure? I don't think it's the right answer, but next. But you're not the first to answer. Okay. Read. Okay.
Fasciotomy.
That's easy. Next is burns and tissue engineering. Which one? This side. Okay. Allograft. Next, we see if it's an allograft. Next question.
Tissue expander.
That side? Okay. Tissue expander. So, please give them a round of applause. Next time, please be looking at the slides being presented in the conference. You will get so many answers. And that was the final game. If you think group 2 won, please raise your hand. They might share with you the 50,000 shillings. If you think group 3 won, please raise your hand. Yeah, you have less mouths to feed. If you whoever thinks it's a tie, please go out. We have to have a winner. All right. And group 3. Group 2. What's your name again? Oh, Beauty and Botox and Brains. Please clap for them for participating in this. And group 3, what was your name? The micro free flap. Please clap for them for also participating. And because I know you're waiting, we will have our sponsors please come to the front. This is the only way we will keep you waiting. We will have our sponsors. Please clap for Britam. They agreed to sponsor us. To sponsor the inaugural residence ball. If you know about Britam, please raise your hand. Please welcome Britam. They will give a short presentation and then we can go to knowing who has won the ball.
Hi, good evening. Good evening, everybody. Thank you for having us. I'll just introduce my colleagues and then we'll say something small and then we present our gifts. Sindio. So my name is Lea Ndinda. My colleague here is TK Thomas Kinuthia, and this is Regina Wambua. So thank you so much for having us. I'll let TK just give us a small talk, and then we'll do our gifts. Send off.
All right, good evening. Thank you so much for having us, and we are proud sponsors of KSPRAS 20 years anniversary. Congratulations for keeping it up for this long. We have existed for the last 60 years and we are so happy to have this partnership with you. We say that we are friends for life, so that as you've spent so many years in your training, and the very difficult, congratulations to both of you and the team that left and the other one. Honestly, some of the things were just passing me by. To say, as you invest in your education for considerable number of years, we want to shorten your journey in terms of your savings and your investments, your retirement plans. We know that in your profession, you hardly exit the stage, you continue practicing, so we want to ensure that as you transition, because we can see different ages here, as you transition from one level to another in your career, we walk the journey with you when you start with your investments from a short-term perspective, and you're doing your mid-term investments and carrying on towards retirement. We are with you from cradle to afterlife, because recently we have introduced the whole life cover up to the trust fund. So we make sure that you're planning for your today, you're planning for your tomorrow, and you're planning for the future generation. So please come get in touch with us. We have a tent over there. And also, most importantly, I know most of you, almost all of you, have professional indemnity covers. Please do come see us so that we can let you have peace of mind while you're doing those complex things that I've seen on screen. So we are happy to come guide you as you do that. We have very good return from our money markets. We have actually, of yesterday, we delivered 11% on our money market fund, which is quite considerable. And we now have the goal plans that allows you to set aside some of your salary and your income to help you plan for the future. For those that have dependents, it is good for making sure that you have peace of mind. Get good medical covers for the people that you love and the people that you care about, so that you are able to have peace of mind while you're building your businesses and you're building your profession. So we'll be more than happy to engage you and work with you through such of plans. So we'll run, as we said, we secure your today, we secure your tomorrow, and we secure your forever. Karibuni sana, Britam. All right, back to you. We are also anxious to award the winners.
Thank you very much. And because I have made it a tie, I will ask one question that will break the tie. No. Anyway, I'm kidding. So, please, drum beats. Drum beats. Louder. What's 50,000 shillings? What's $50,000? What's 50,000 pounds? And coming up, first runners up, who will be awarded by our sponsors, is Group 3. That was close. That was close. You can just stand and get your gift hamper. Oh, yeah. Don't worry, I'll tell you, but... Please clap for them as they receive their gift hampers. Each of you will grab a gift hamper. Yeah. All right. As you exit the stage, faster than you came in. Please give it up for the winners of the inaugural Residence Ball, Group 2, also called Buttocks and Brains. I will invite our president, Prof. Nangole, to come and award a blank check. But immediately after, we are getting it back to write the number. And our sponsors will also give you some gift hampers. Please clap for them. I'll also invite to the stage Dr. Joey, who was the person who came up with this whole charades. Unfortunately, the was bringing the check delayed, so we had to come with a blank check. So congratulations to Buttocks and Brains for winning the inaugural Residence Ball. Please shake your hands. And please. So, the check is, the name of the check is Jos Njuki. And it's for please stand here with our sponsors for the photo. Thank you very much. Please clap for them. Please clap for them. Please clap for them. And now, because you've been listening all this time and because my mouth is dry, I need a cocktail. And you need a cocktail, so we will proceed to have the cocktail. And I will invite... Where is the cocktail? Oh yes, I will invite Dr. Mkami to give us the directions from here. Thank you very much. Thank you for participating. We will send you certificates for participating in our inaugural Residence Ball. And I hope we will see you next year for the second inaugural ball. Please clap for yourselves. Thank you very much. We have you back to the chair.
Thank you, Dr. Laura. That was fun. Thank you, residents, for cooperating. That was amazing. Looking forward to next year's Residence Ball. So we are definitely now shifting gears. We are going to our cocktail. It's going to be at Sokoni. So Sokoni is, we are going to the middle and a left. You will see the music will call you. Follow the music. So let's go have fun and unwind. Karibuni. See you tomorrow at what time? 8. Nimesikia mtu akisema 9. 8. Thank you for a lovely day.